do some introductions as we go through the meeting. Apologies for absence, Julie.
Yeah, we've got Alan Griffiths, Janine Lewis, Tim D, and that's all I've been notified about.
Okay. Any declarations of interest? No. Okay. Minutes of the last formal meeting. Any corrections, please? No, everyone happy? So we'll move on to item 5, election results paper. Julie, can you just?
It's just a note, and it's just to formally note the outcome of the elections.
Fine. Thank you very much. And so item 6, external auditor's report to the Council of Governors, which I must say I thought was a very clear report. So Ernst & Young, Maria, are you going to speak to this? Oh, Tom, sorry.
Yes.
Sorry, just before you start, Tom's got his hand up.
Of course.
Tom?
Julie, now that we've got the elections done, could you circulate a list of the constituencies and the governors? It all gets a bit confusing with the uncontested and contested, just to make sure I've got everything straight.
Yeah, of course, I'll do that.
Thank you very much.
Thanks, Tom. Okay, back on to the audit. Maria, over to you.
Thank you, Chairman. Yes, it was a good year. Thank you for recognising that, and obviously I'll assume you've read the report. However, it is important that I just take you through what some of the outcomes actually mean, and our responsibilities. It's something I need to do with the Council of Governors, so I will do that quite briefly. So clearly, one of the responsibilities I have is to give an opinion on your financial statements. You'll see that opinion was unqualified. I would like to say also that the audit this year went a lot more smoothly than last year, and I think the wash up at the end of last year really helped us. We had a really open discussion about what worked from both teams' points of view, and we played in a lot of the kind of suggested actions from that into this year, and we've just been through a similar wash up this year for next year. And I think each time we do that, we get more efficiencies, and we iron out any kind of bumps in the road that you do inevitably get through an audit. The other aspects of our work are to look at the remuneration report and consistency. So we look at things like your annual reports and say, are they in line with our understanding? So are you writing an annual report that makes sense based on what we know of you as an organisation? And I had no concerns at all on either of those aspects. From the point of view of value for money, those of you who have been around for some time remember the old value for money conclusion. We now have a value for money commentary. But again, had there been any concerns with regards to your arrangements and your procedures in place, that would have then created a risk, additional work, and potentially an impact on my auditor's report. And none of those scenarios played through. So it was a good value for money commentary and a good outcome from the point of view of that piece of work. I had no reason to refer anything up to the Secretary of State, and also no reason to use any of my other auditing powers. So ultimately, it was a clean audit. It was an incredibly hard and fast-paced audit on both sides. The timescales always feel incredibly tight. There's always more that we can do to improve things, to improve the records, the responses, and the way in which, certainly from our side, the way in which we ask our questions to make it clearer. So we're always looking to capture those improvements through our wash-up meetings. But yes, it's been a good year. And I would say for the Trust, looking wider across the NHS, you've done well, because I know a number of organisations have struggled in this year to get their accounts through, to get them audited, and to get such a clean report. So I think you're in a good place.
Thank you very much indeed for your efforts and also your nice comments. I think what I'll do is open to Governors, really, for any questions or comments you wish to make. It's your chance to test things. Okay, well, Maria, thank you very much for your time. Oh, sorry, Tom. Yeah, Tom.
Well, just to say, it looks a very good report, and we ought to offer our congratulations to Paul and Gray and his team, and to the auditors for a very clean presentation, helpful presentation. Thank you.
Yeah. Well done. Thanks for that, Tom. Support that. Okay, in which case, Miriam, we'll let you go and see you again soon, I expect.
Thank you very much. Thank you.
Thank you. Okay, well, shall we move on then to item 7, the Trust Annual Report and Accounts? Julian?
Thanks, Martin. I've got a short presentation. There it is. And then Paul is following on. This is a presentation, if you recall, that I will also use at the AGM. There's a couple of slides at the beginning that are for the benefit of the public rather than for governors, so I'll skip through them. The reason why I do it is every AGM I get a question about the Royal Berkshire or Wexham Park Hospital, so there's a couple of slides just making sure people know which NHS organisations AGM they're at. So if we can just move to the next slide and probably the one after that, please. Yeah, that's just about us, which you know about. Next one, please. Okay, so I was going to say, obviously, during the course of the year, we did quite a lot of work with our stakeholders, public, patients and carers, coming up with our new mission and vision, which we're pleased with. We think it's very contemporary. We think it's meaningful as well as memorable. And so the mission to maximise independence and quality of life. You can always wordsmith this to death, but actually, if you think about the nature of our services, it's probably as accurate as you're going to get. You know, you take a child with significant disabilities who we're looking after, or you look at somebody maybe on the end of life pathway. It is always possible to maximise independence and quality of life. And conversely, one could argue that health and social care services sometimes have not always maximised independence. Sometimes they probably overstep the kind of mark. So that for me, it's a philosophical kind of approach that we've got as an organisation, which I think succinctly describes who and what we're about. The vision, again, I think is pretty easy to remember, and again, hopefully resonates. Just quite simple: a great place to get care and a great place to give care. Both things which we can kind of measure. There are patient experience, which we're going to be talking about later, and staff surveys, etc., which again I'll touch upon in a minute. And the next slide just confirms again for governors, which will be familiar to you, that the core values, we did actually look to refresh them, but actually the existing ones were still felt to be highly relevant and well known in the organisation. So caring for and about you is our top priority. The commitment to provide good quality, safe services is a prerequisite if you're going to achieve that aim around caring. And then working together to develop innovative solutions is a very inclusive, I think, final value, which is kind of working together with patients, carers, inclusive in terms of the communities, but also in terms of different staff groups, teams and everything else in terms of the importance of multidisciplinary work. Next slide, please. In terms of some significant changes, I think during the course of the year, it would be extremely remiss not to mark some landmarks. David Townsend, our Chief Operating Officer, had been in senior positions in Berkshire Healthcare for 10 years and had driven an awful lot of change. David Buckle, Martin, correct me if I'm wrong, but 7 years, I think, at least as a non-exec director. He was a clinician on the non-exec director clinician, GP by background, so he led the quality assurance committee amongst other things. And Paul, I think 3 terms, 9 years as a sort of governor, and obviously a substantive part of those 9 years as the lead governor, and that gives us an opportunity to welcome Tamina in the chief operating position, Sally as our clinician, Ned, and Brian, obviously familiar to you all now, as the lead governor. So a few goodbyes and obviously some important hellos as well. And just, I think, sort of taking that opportunity to mark our gratitude and thanks for the hard work and dedication that those 3 had shown over a very significant amount of time. We don't have a lot of turnover, so this type of slide is quite unusual at our AGM because people don't leave very often. So I think it is quite a seminal moment. Next slide, please. If you want to read about what we've done, and there is pages and pages, the annual report talks about all our service developments. The report I tend to look at, if I'm honest with you, I want to remind myself, is usually the quality account, where you'll see a significant amount of what we've done during the course of the year. I'm boiling it down to 2. You could quite rightly pick me up and say, why didn't you identify those 10 or 15 other things? But I've chosen these 2 because I think there's some strategic significance to them. The first is we saw the increasing development of virtual wards or hospital at home in physical healthcare. We saw the number and size of virtual wards. So people who traditionally would have been treated at Wexham Park Hospital, Frimley Park Hospital or the Royal Berkshire, been treated in their own home with face-to-face visits by geriatricians and our clinicians' multidisciplinary team. And our audits suggest that those people would otherwise been in hospital, or we've been able to take people out of hospital and reduce their length of stay. We've got very good evidence that they are popular with patients, as those national surveys. So the Nuffield Trust, which is one of the leading health think tanks, produced some research in the summer saying that they are way more popular than actual wards for very obvious reasons. People like staying at home, and they're very popular with clinicians too. So I think this is my personal view, is that with the crumbling infrastructure, with rack planks being found in hospital buildings, but education buildings, I think starting to shift the locus of care into people's homes, which is what we've been doing in mental health care for decades now, will be the future of healthcare. And so developing these virtual wards more, I think, is a highly important and strategically relevant sort of ambition for us. And then in the mental health area, we further developed our mental health integrated community services, big mouthful, but effectively specialist teams working directly in primary care to be able to offer support for those people with more severe mental health issues. So those people who wouldn't meet the criteria for talking therapies, who've traditionally perhaps bounced around between the GP and community mental health teams. So embedding experienced clinicians in primary care. We started this as an accelerator site in across the Frimley patch, so East Berkshire for us, a couple of years ago, but these are now rolled out across the whole of Berkshire. They're still, to some extent, settling down and finding their way, but they've no doubt filled a really important gap between very specialist care and the GP. And over the next year or 2, what we're looking to do is thinking about, okay, if they're now in place and filling this, how does the totality come together? And so next year, I'll be talking about something called One Team, which is about how we coordinate the range of specialist mental health services to make sure that they are coordinated, joined up and offering a personalised service, which at the moment is not always the case. Next slide, please. We have been working hard, and again, we previously talked about this in our annual report reviews around anti-discrimination, about actually making sure we're a fair, equitable, diverse and inclusive organisation. And that's something we're committed to. When we look at progress, we can see progress on most fronts, although in relation to race, objectively, we've made less progress than we have in other areas. And we've made a commitment to be an anti-racist organisation. Now, lots of organisations do this, but for me, the defining factor about anti-racism is it's not enough simply to be non-racist. This is about taking action to address some of the underlying issues that result in racist behaviour. And it's a clear acknowledgement that racism exists, that sometimes it's very obvious. So we have members of staff who are racially abused in going about their day-to-day business. But we also have structural racism. So, for example, when we look at waiting lists, both nationally and locally, when we look at who's waiting longest, it's often people from Black, Asian, minority ethnic backgrounds, not related to any condition or risk profile. So we've got 5 key work streams to take action that will make us a fairer and better place. So if we go back to our mission around great place to give care, great place to get care, this is really important. So work streams around recruitment, retention, progression and conditions, policy and practice, education and engagement. So making sure people understand what it is to be non-racist and what their role is. Looking at incidents as they happen, working with the police much more proactively to support, and looking at patient access, experience and outcomes. And this is very much getting everybody at every level in the organisation to be much more curious. So how long is your waiting list? Okay, that's one thing. is there any differential in your waiting lists? And do we need to take action in relation to that? Have we got different rates of detention for people from different backgrounds? And do we need to take action because actually it's inequitous, it's not fair? That's really what we're about, action orientated, doing something about it. We've seen the stats, we've seen the data, and we're absolutely keen and committed to do something about it. And the board have full steam behind this. Which is good. So I think we're in a good place in terms of alignment, getting the organisation in alignment. The real acid test will be in 12 months' time when we can report actually what progress we have made. Next slide, please. Of course, this report covers the period April 22 to March 23, and the Letby horrors didn't come until after that. But the nature and culture of the organisation is something we've been working on for a very long time, because we've seen it integral to absolutely everything that we do. And speaking up for us is about making sure we provide safe, effective services to the people we serve, as well as being a safe place to work and get care and give care. And what you can see on the slide here is the National Staff Survey, where thousands of our staff take part. And you can see on key questions, increasing improvement in people's ability to feel free to speak up, that they listen to, and that things are followed up, which is absolutely vital in terms of an organisation. Obviously, something that's been in the press about the NHS. What I would say is that different parts of the NHS are in very different places. By no means are we perfect, by no means are we complacent, but if we move to the next slide, at least you can see how we're doing compared to our sort of comparators. So in terms of freedom to speak up, key questions about people being able to speak up, and confidence that the organisation will do something about it. Out of 225 organisations, we're ranked 12th at the moment. In terms of organisations very similar to ours, community mental health, we're third in the region, top in our integrated care system. But as I say, we're not complacent. We're continuing to make sure, I suppose with the scores we've got, what we're doing now is honing in on those areas that feel less confident, or working with those groups of staff who don't feel as confident. So in a way, we're in a position where we can start to segment and start to think about those areas where we might have issues in the organisation. And we know that if we attend to those, those organisations that have that culture where people are able to speak up are safe organisations, but also they're innovative organisations, because if people are prepared to speak up about things that are really worrying them, they'll also speak up about things that might make improvements in the organisation too. And so that's been a really important piece of work. My final slide is a huge thanks to our staff, and just to bring you up to speed with where we did in last year's National Staff Survey. In terms of staff engagement, which is the most important indicator, so that's people's happiness in terms of motivation, recommend it as a place to work, recommend it as a place to get treatment, and a promoter of the organisation. We came top in the country in terms of staff engagement. And that's important because it has research says it's directly related to the quality of care you provide, which, as we saw, is our top value. So we were obviously delighted, and that's the third successive year we've been top in the country out of the 225 organisations. And you can see, I won't go through each one, but we're simply above average or top scoring in a number of the staff survey areas. Again, for us and for the board, what we've been focusing on really is not that high level score now, which is pretty stable, but again, focusing on teams, areas and individuals where we can make further improvement to make sure we're not complacent and we can continue to drive it. But without sitting on the fence, given the incredible challenges we've had during the last few years, we're proud of our achievements in this area and awfully proud of the staff who work at Berkshire Healthcare. Martin, that is a, obviously a truncated summary of the last sort of 12 months. Clearly, I can't cover everything, but hopefully giving a flavour of some of the things that I think stood out and perhaps are particularly relevant in the current context.
Julian, thank you very much. Very clear, very helpful. just before I throw it open to governors for questions, just a couple of things that I wanted to comment on. One was the mission statement, and one of the things that strikes me about our mission statement from what it was before is it very much focuses on the people we're trying to care for, i.e. the individual patient, rather than the organisation. So before we talked about, you know, this trust being the most admired trust, or words that effect. Now it's very much on the patient as being the important thing. Are we delivering care? So I think it's another aspect of why I think it's a really good change. And on a different matter, on equality, diversity, inclusion, we are arranging training for governors, and our EDI team talked to them yesterday about having something to bring you up to speed on what we're doing and how you can help. So just a couple of sort of factual things. Okay, over to governors. Could you stop sharing the screen and we can see everyone? Ian.
Hi. So firstly, just to echo that point about the mission statement, I mean, you see so many mission statements, as you say, we're going to be best at this, but this is a very patient focused and staff focused mission statement. So I think that's very admirable, and you know, I mean, it's a pretty great report overall, isn't it? So well done on all of that. Just one question: do you understand why BAME patients wait longer?
Not in its entirety. So that's a really good question, and so we need to get to the bottom of it. But we do know some significant reasons. So some of it is about understanding access and take-up of services are quite differential. So if we look at patients who perhaps self-refer in, we definitely have different. We definitely have a different between groups. So if we look at Slough, for example, the take-up of services refer in is there's a huge differential, say, between that and Wokingham. So understanding, and that's the case not just for Berkshire Healthcare, but across the range of services. So there's something about understanding our services, making sure we're reaching those groups and serving them better, and also something about breaking down barriers where there may be concerns, mistrust, and all the rest of it. We certainly know those things are in existence. But also there may be other things, Ian, and I think that goes to the heart of your question, where I said one of the things we're doing now is starting to sort of forensically explore some of our waiting lists, so we don't assume that we know the answer, and actually we get to the root cause of the answer. And I think it might be slightly different for different services in different locales, but the point being is it's now an area of focus for us, whereas in truth we've often just focused on sort of longest waits, average weights, that type of thing, rather than really starting to get into the detail and segmenting that. But particularly the work that's gone on nationally has shown that disparity, and we need to understand our position better. So I'd say, Ian, at the moment, partially, maybe that's an honest answer at the moment. Yeah,
because I guess one of the problem with this whole area, of course, is that it comes under this title racism, and you know, racism can be, you know, someone doesn't like a certain culture, so they kind of push them down the list, you know, obviously. But at the other end, this covers cultural differences. So you touched on access and so on, and whether certain communities or cultures are simply less pushy about self-referring or something. So that's, in a sense, doesn't quite come over as racism. It's not the organisation being nasty to people. It's people culturally meeker, if you like. So I think there's a slight issue with it coming under the title racism. But I also wonder, then, we talked in a previous meeting about the role of trust membership, and I wonder if trying to address some of these, if you like, community or group, and I hate the word BAME because it kind of lumps them all together as one, and they're not one. You know, it's a whole diverse range of attitudes, people and individuals, but there will be sort of communities there, and I wonder if the trust membership in some way can somehow access community leaders to help spread that. So, you know, you've got an individual trust membership at the moment, but there's this, I'm not quite sure what I mean, to be honest, but a sort of community group membership of trust that then you can use that to filter down into those the individuals that need to self-refer or whatever.
Yeah, perhaps Julian, I could just take. We've been trying for a long time to increase the diversity, of governors to reach those parts where we're not reaching at the moment, and it's a long journey, but we must keep pressing on to try and involve those communities in the decisions the trusts make. Ian, thanks so much. We've got lots of questions, and we haven't got that much time, so I'm going to now press on. Tom, next, I think.
Admirable report. Thank you very much, Julian. And I would like just to say, if we do manage to move some more effort into prevention, there is the question of how different people see the boundary of when an issue is a medical issue. So I think that's a big thing that we're going to have to look at again, sort of in the future.
Thanks, Tom. John Wellham, I think. Are you there, John?
Right, can you hear me?
Yeah.
Splendid. You haven't mentioned, Julian, the integrated care system, and obviously it's 1 year into its life. Obviously, pros and cons. Is it possible to give a quick overview of how you think it's affecting the work of our trust?
Yeah, thank you. Yeah, so I did skip over the ICSs because it was on the first slide. I'll give you an honest answer. So philosophically, they have been a good thing, and the preceding things before them over the last 5 years. The philosophy being, actually, if you want to resolve some of the really difficult issues, it is better that health, social care, voluntary community sector cooperate and work together in order to address those issues around personalised, person-centred, coordinated care that we're after, and also to go back to that earlier issues about how we manage the population. The issue, I think, as I've previously said, for integrated care systems, they don't exist in a vacuum. And one of the things that I think certainly has been a challenge is, we're in two, so that often leads to sort of quite conflicting priorities, which don't always sort of make entire sense to us. And secondly, it's a very crowded space at the moment. So you've got the Department of Social Care, Health and Social Care, you've got NHS England, you've got regional offices of NHS England, you've got 40-odd integrated care systems, you've got trusts, and then you've still got legacies from the Lansley reforms 12 years ago of health scrutiny overview committees and all the rest of it. And what I would say is that integrated care systems have landed and were sort of born into a bit of a storm, really, in terms of both the challenges that have existed post-COVID financially and in terms of the structure of the NHS. And they've been slightly overwhelmed with a large degree of priorities. And I think that for them to be successful, they probably need to scale back in terms of what it is that they can focus on within the context of that overall architecture that I just described. So I'd say it's been quite a difficult year. We get on well in terms of relationships, but I think the complexity of the system which they and us operate in has hampered quick, clean decision making at times, would be my honest summary.
Okay, thanks so much, Julian.
Thank you.
Thanks, John. Brian, then we'll move on.
Yes, just a very quick one. Is there a correlation between what we're discussing and areas of health inequality?
Yes, absolutely. So yes, I mean, quite a lot of this will be driven by exactly those things. So attending to sort of root cause health inequalities, maybe rather than just the symptoms, will be an important part. And that, Brian, I mean, it goes just to that last question, which is where integrated care systems are supposed to do some coordinated work around that. They've certainly been very ambitious about talking around it, but actually intervening in terms of housing, education, health, poverty, substance misuse, etc., which are the far bigger drivers. They account for 80% of health inequalities. Health provision itself only about 20%, is something that, unless we want to see the dial shift, we'll have to improve. As you know, these usually take long-term interventions, and we are suffering from short-termism. people want to see results much quicker. So that's one of the challenges, I guess. I guess that might be behind something that may lie behind your very question, I wonder.
That was the answer I expected, but thank you for the detail.
And just to remind you before we move to Paul on the finance side is that one of our 5 key strategic themes is health inequalities. So it's built in. Indeed, our discursive trust board meeting in October is one of the key topics there we're focusing on, is getting updated on our work on that. So this is very much part of our central to our strategy. Okay, thank you very much, Julian. Paul, you've got to say something about finance. Tell us how wonderful we are.
Yeah, thank you, Martin. If you can just share the slides, Linda. Okay, thank you. If you just got the first slide, please, Linda. Thank you. So just trying to set some context for 22-23. So the plan that we set for the year was obviously moving into, at the time, post-COVID environment. And what I mean by that is that the NHS and we were moving back into kind of the financial regimes that we'd operated on pre-COVID, which means less of a reliance financially on central COVID funding. We also entered the year with high levels of patient demand, increasing pressure on our services, and also an extremely challenging economic climate with inflation rising to levels that we've not seen for decades. So increases in RPI, utilities, etc., putting pressure on the finances. So we agreed with the board and set a deficit plan for 1 million for 22-23. Within that plan, we assumed that we would need to deliver efficiencies in the order of 10 million. Given our cash position and given the need to continue to invest in our estate and IT digital infrastructure, we agreed a £11 million capital investment programme, and the combination of the deficit and the capital expenditure programme meant that we were expecting to see a 7.2 million reduction in our cash balance. If we just move on to the next slide. Thank you. So in terms of our actual performance, overall, I would say that we did significantly better than we originally anticipated. And despite planning for a deficit, we delivered a break-even position, which was £1 million better than we had originally planned. You'll note from the table that we saw a significant increase in our income during the course of the year. This is the result of several factors. So we received national price inflation, as we do every year, which is an increase in the income that we get from our NHS partners, but also on our other commercial contracts and local authority contracts. In addition to inflation funding, we received several specific increases in terms of our funding. So one being the mental health investment standard, which is a higher than inflation increase in funding from our ICBs to recognise the need for higher than inflation funding growth needing to go into mental health services to address historic underfunding compared to other providers and other acute services. We also received additional service development funding, which again is targeted funding for mental health and community services. And finally, 9 million of the increase we received at the end of the year as final settlement for the long-running Agenda for Change pay dispute. Offsetting that increase in income, you'll see that overall our expenditure rose by 31 million as well. The vast majority of that effectively was increasing our staffing costs, and that's down to 2 key elements. So one, the aforementioned nationally agreed pay awards and inflationary pay rises. The second is that we saw our substantive workforce increase by around 200 whole-time equivalents during the year, aligned to the investment that the ICBs and other commissioners had put into our services. In terms of our efficiency programme, we fell short but still delivered 5.2 million of efficiencies, primarily driven by reduction in costs of short-term placements and long-term learning disability placements, and we're continuing to try and drive down our property costs through reduction in the amount of space that we lease. And in this particular year, we saw some technical efficiencies through VAT and up-to tax initiatives that we put in place with NHS Property Services. In terms of capital, we agreed an 11 million investment. We continue to put money into our estate. So during the course of the year, we had 3 significant estates programs that completed. So we finalised the move from our old headquarters in Bracknell, Fitzwilliam House, into our new collaborative space in London House in Bracknell. We expanded our MSK and physiotherapy facilities through the development of a new facility in Newbury called Adlam Villas, and we moved out of some old substandard accommodation in Windsor into a new facility called Foundation House, which again is housing MSK physio services. Aside from estates, obviously, we're heavily reliant and continue to be reliant on IT. So 5.1 million of investment in kit developments and strategic IT investments. We closed the year with a better than planned expected cash position, so healthy cash reserves of 55 million. And I think, as Maria had already said in the previous presentation, importantly, we received an unqualified audit opinion from Ernst & Young. So if I can just move on to the final slide, please, Linda. Just setting the scene for 22-23. Obviously, the operational and economic environment still remains challenging, similar to what we saw as we went into 22-23, but with the addition that probably the finances nationally are tighter. We've set ourselves a plan of a 1.2 million surplus for 23-24, and this includes a higher level of efficiency requirement at 14 million for the year. As I've said a couple of times, we're in a healthy position from a cash perspective, so we've agreed a 12.5 million capital investment programme within the bounds of agreement with ICS partners. And should we deliver the surplus with that level of capital investment, we expect to see a decrease in cash of 8.6 million. I'm happy to take any questions, Martin.
Okay, thank you very much, Paul. Any questions? Could we have the slides down and the screen down? That's it. Thank you very much. Right, Graham Bridgman, I think first.
You sort of answered a question I was going to ask in the presentation, which was whether by cash you mean what I understand as reserves. My question is, therefore, within that, do you have earmarked reserves and general reserves? And if so, how's that split out?
So we don't have them split as such. So effectively in real terms, that's the amount of cash that we've got in the bank. So we have a threshold at which, from a planning perspective, we wouldn't want to go below, and we review that on an annual basis. In terms of the level of capital investment that we can make, that's very much governed by agreement with partners across Bucks, Oxford, and Berkshire West ICB. So we need to agree a level of capital expenditure each year, and that's very much is driven by how much cash we've got and available allocations.
Okay, John Jarvis.
Yeah, good morning, Paul. Yeah, on the total expenditure, you've got 349 million. But the breakdown of how much you spent on the various areas is shown, but not the change between last year and this year. It would help us to see where you achieved, did you achieve the various commitments you have throughout the year? In other words, if you've got to pay over, what, 240 million, I haven't got the slide up now, so I can't see it. But if you've got that, what was the previous year and what was the difference? That there's about 8 or 9 different items there. Can we break them down?
So they are actually broken down in the annual accounts. It's something we can maybe look at improving in terms of the presentation for next year, John. It's just one. It's one of those. It's one of those trying to keep the slide not as busy as it needs to be with lots of variances. Because I think the key thing for us is kind of what that overall position is on our expenditure position, rather than necessarily the detailed breakdown of whether we were exactly 100% in terms of setting the budgets for drugs versus premises.
Right, can we access that at all?
Yeah.
Yeah.
We can. Okay. I'll ask Julia how I can find that. Thank you.
Thanks, John. Tom Lake.
Paul, can you say a bit more about the ambitious plans for efficiencies and capital?
Yeah, so in terms of capital spend over the coming year, we've got a couple of estates programs that we expect to come through. The main one is going to be that we're moving out of the old forge, which is a building on the high street in Wokingham that we've been in for a number of years, and we're relocating about 10 doors down to a new facility called Resource House. So we'll still have a very strong presence on the high street, as it were. We're also relocating some of those services into Wokingham Hospital as well. So overall, we're reducing the footprint and trying to drive. We will be driving an efficiency out of the estate there by utilising unutilised space in Wokingham Hospital plus a smaller building in Wokingham. We've also got plans, obviously, around continued level of IT investment in terms of kit replacement. We expect the workforce to grow. As the workforce grows, we need to provide them with IT kits. So again, there's a further investment in IT in terms of making sure all of our staff have the appropriate level of IT equipment they need. On the efficiency side, we've got the aforementioned efficiency from the estate. So again, trying to reduce the amount of estate that we're using, because obviously we've seen an increase in number of people working from home, which means that we've got buildings that aren't utilised as fully as they previously were. So we're trying within the confines of lease timings to try and reduce that cost. We know that we spend a lot on out of area placements and extra contracted beds. So again, we're trying to drive down that number in terms of volume and price. Just trying to think, we've got some digital efficiencies coming through from move to new telephony solutions. And then we've set each of our operational divisions a control total, which effectively is a financial envelope which we expect them to operate in. So each division will be effectively employing kind of a number of schemes within their own divisions that are probably smaller value, which is enabling them to come in within their control totals.
Thank you very much. That's very helpful.
Okay, thanks, Paul. I think we need to move on, but can I just say, both Julian and Paul, I think on behalf of the Govenors, that it's been a great year and the Trust continues to perform at a very high standard. And also that I think the executives are never complacent. That is, they're always looking at improving care, improving finances in quite difficult circumstances. And you know, you haven't got to do much watching of the politics, of the national politics, and I think finances of NHS is going to be difficult for several years to come, regardless of political decisions that the population makes. So I think we got to keep pressing on with these, delivering the best care we can in the most efficient way we can. Okay, thank you very much. Now I think Sue McLaughlin has been called away on a fairly urgent clinical matter. So I'm going to ask Katie Humphreys if she's able to take item 9, the carers strategy update. Katie, are you able to respond?
Yeah, absolutely. I can do that. I have got a few slides to share as well, if that's okay. I will try not to be death by PowerPoint. And hopefully they should be popping up now. Okay, so I will put my little timer on as well, because I know you're we're conscious of time. So when we talk about carers, what we're really talking about is anyone, including children or adults who looks after a family member, partner or friend, and they need help because of their illness, frailty, disability, a mental health problem or an addiction, and they can't cope without that support. So this graphic is quite good because it actually shows that we don't always identify ourselves as carers, that often we see it as that extension of a family relationship. So we could be a grandparent, a friend, a brother or a sister or a loved one. And also it's not just about performing personal care. So it could be about help with medications. It could be that phone call that checks in on someone. So it's trying to make people aware that they might be fulfilling that caring function, and if they share that with us, how we can help and support them. So what is our strategy? Well, we have based it on triangle of care and NICE principles and looking at best practice. So we've got 6 standards that we're working towards to make sure that staff are carer aware, that they're identifying carers and involve them in planning of care, and we're referring carers as appropriate. So they recognise their own health and well-being, and that we've got staff that are responsible for that and making sure they've got that information across the care pathway, and also that we're getting the carers feedback in all that we're doing. So because of the myriad of services, we have identified that we can have level 1 and level 2 services. So the expectation would be all services would reach the first 3 standards. Other services, particularly the mental health environments, would work towards all 6 standards, but that realistically we should all be working towards all 6 where possible. So last year I presented the information about what we were doing. My role was fairly new, so I'm the carers lead for the trust, and I work with the different teams to try and support and encourage that engagement and involvement with carers. So last year we said that we'd worked on our e-learning training. We'd introduced that for all staff to complete. We'd refreshed the website and the intranet. We were working on carer feedback processes. We have got accreditation with the triangle of care, and that in development we were still working on more resources, a specific project with our veterans called Mind the Gap, our carers charter and our self-assessment tool. So I just want to give an update about what we're doing with that. So my role internally is to work with all the different services, try and get involved in specific projects. Julia mentioned earlier the one team approach, so we're making sure we've very much got the carer's voice within those discussions that we're having. And externally I work with the NHS England, linking with ICS partners, so I attend various carer strategy groups. I've been linked in with adult social care about some of their carer strategies in Bracknell, Reading and West Berkshire. We're also trying to update our e-learning training, because we're recognising that whilst a lot of staff are enrolling on it, they're not necessarily all completing it. So we've got a yellow belt QMIS project looking at that. And then we refreshed our website and our internal intranet called Nexus with some of those resources, and also this video that we produced with some of our staff who are carers that talks about whether you look after someone and are you getting that help and support that you need. So there's a new process with Carers Trust about the triangle of care. So we've fed back to them with our data on our annual return, and we're going to get that 2-star accreditation again. So the Mind the Gap project was very much looking at supporting veterans. So we had a report that was published within Carers Week. We had some focus group and one-to-one sessions with their carers. We've come up with a Op Courage Family and Carers webpage so that people have got targeted information about the terminology. We took their feedback on board regarding that. And we've also produced some educational videos about understanding the impact of military training on veterans and their family members, the challenges of transitioning to that civilian life, and tools to help them manage their relationships and well-being. And within those services, they've got a dedicated family liaison and support lead role. So we've very much been linking in with the teams, making sure everyone knows it's their responsibility across the team to identify carers and signpost or connect them. But for carers that might have more complex issues, they work exclusively with the family liaison and support lead. Again, we've talked about those resources available for staff. So we've got some resources, particularly about confidentiality and information sharing. We know that it can be a challenge, particularly where there's issues of consent and capacity about what information you can share. But it's also about knowing that we can engage with people. And if you can't share information, why you can't share it, and have that conversation. So making sure that staff are feeling confident and competent to have that conversation. Other resources have been developed. They're available either on our website or on Nexus. And if we've we don't want to keep reinventing the wheel. If things are out there already, like the Carers UK looking after someone, we signpost to that information. And we've also, through the Bob ICS, got access to some additional resources that carers can use if they use this code, so they can access that through our services and our websites, etc. So what we introduced in November last year was our Carers Charter that we co-produced with carers, and it really pledges to identify carers, ask people in our services if they have a carer and how they want them to be involved, that we want to listen to and respect the carers and recognise that they can be that expert partner in the caring relationship, informing and involving them in our services, and as I say, explaining why we can't if we can't, and connecting them onto that support, which may not be provided by us. It might be provided by local health and social care services or our voluntary sector partners. So one another way that we wanted to do that was a toolkit. So in Carers Week this year, we had a workshop for our staff to share with them this toolkit that we've developed. So basically, where I've been working with different teams over the last year, we've put into that toolkit examples of the sort of best practice, what they're doing, so that they can make contact and learn from each other about how they can engage with families. So we're sharing and showcasing those activities. So again, what we wanted it to be was very action orientated. We know the services have got lots to do. So where possible, we wanted to share that good practice, show that how things might work in different ways in different settings, be it a physical health or a mental health or a community or an inpatient setting. So we've got various bits in there, like questions that they might ask as part of an assessment. If you're having a carer support group, how you might promote that through social media, and how you might, as I say, have that carer support model that all staff should be asking the questions about the support that their person provides, giving them general information and then connecting them to ongoing support. So we've tried to create lots of templates that teams can adapt or adopt so that they're not starting from scratch. And as part of the toolkit, there's also an action plan, because what we want to make sure is we know lots of good work goes on, but historically we haven't necessarily had the data to prove that. So as part of the process with this self-assessment review process, we've got a form that we sent out, a Microsoft form. We've gathered that feedback and we've produced a dashboard to show the compliance against the 6 standards. Now that looks pretty horrific on there, but hopefully if I just share my screen, this is still in development, but it's basically going to be able to show that across the trust how we map to the compliance to the 6 standards. You could select on your service how you're doing for the different directorates, and then specifically in an individual team or service that's replied. There's also, as you'd imagine, the mental health services where Triangle of Care has been in place for a long time. You can see that there's lots of greens, and then we'll be able to target those areas where might need improvement. So again, this looks pretty horrific. It sees all this questions here and the different services, but what teams and services will be able to do is filter on a mental health environment. They then would be able to filter on the areas that are red, and then they'd be able to see the areas that they want to target as part of their action plans and their improvement processes. So hopefully now we will have that data and areas to be able to drill into and work with, share best practice where it's really working well, and also then make improvements in areas that might not be so used to it. So we said we'd do that, and what we have done in 2023 is hopefully achieve all those things, as I mentioned at the start. So the next steps will be continue to work with those action plans, target those areas for improvement, hopefully introduce some friends, family and carer champions so that they can help us to work with teams to make those incremental changes in cultures and behaviours. I'm also linking in with the clinical education team to make sure that as part of student nurse preceptorship and HCA development programmes, we're actually making them think about friends, family and carers from the outset. So hopefully the future workforce will always have friends, family and carers at the heart of their thinking too. We're looking with our working carers, because we know a proportion of our staff are working carers, how we can support them, and we'll also be reviewing our carer strategy in 2023. So our mission is still to refresh our strategy and embed our plans across the teams, continue to create that carer friendly culture. We pledge as part of the charter to identify, recognise, inform, guide and support carers, and through our initiatives it will be increasing the number of carer champions, improving carer data and recording, and adding resources to the toolkit. So hopefully that is a whistle-stop tour of what we've been up to, and I'm happy to take any questions.
Katie, thank you, and thank you for going through it so quickly. It's a really important topic, and it's good to see the progress. Governors, any questions, please? Oh, who's number one? Somebody's number one. Oh, Ros.
Thanks, Martin. Thank you, Katie. That's great to see such a huge amount of progress since last year. One quick question. I'm aware in some other trusts there are carer peer support workers. Do you have any plans for those sort of roles in the trust?
So there is a project with lots of lived experience workers. So it's something that some teams will be looking at there, and as part of their roles, some of the peer support workers that we have also have a carer element to it. So we do have some dedicated carers leads, and they will be looking towards that more lived experience perspective as well.
Okay, thanks.
Right.
Okay, yeah, just a quick one, Katie. I read in the meeting papers touching on the self-assessment review by the services. 61 services have responded. What's the plan and progress for the others? How are we going to catch up with them?
So this is part of my learning about the form, I have to say, because originally I just left it name of service. So I need to for next year to be more prescriptive and actually have a drop down menu of those services. So at the moment it's I'm going to all the different team meetings, or they're in the new structure, their leadership meetings for all the different divisions that we've now got. So I'm going back, refreshing, reminding them, asking them to tell me what teams they'd expect to see on that dashboard. So I'll have a bit more of a control and contrast of those names. And next year I'll make sure that I'm more explicit in who I want that response from. So I'll be able to name and shame.
61 seems a good response anyway.
Yeah. Thank you.
Thank you, Kate.
Thank you, Brian. Thank you. Well,
And
Kate,
we'll just say,
please,
sorry,
Katie.
one last thing I forgot to say is, so we did have 3 governors, or we do have 3 people that were governors on we have a Friends, Family Carers steering group, but 2 of them are now no longer governors. They still want to stay on the Friends, Family steering group committee, but we were just wondering if any other governors wanted to put their hand up to join that group as well. So I'll leave that with you, something to think about.
That's great, Katie. Thanks so much. I'm sure they will, and we'll do it through Julie, I suspect, so that you don't get flooded with thousands of governors. Okay, well, Katie, thank you very much indeed. Really good stuff. Right, the presentation we had to skip over was from Sue McLaughlin about reducing assaults on staff, and Sue had to be called away urgently, but I think she's back, and we've got a few minutes, Sue, if you're able to take us through your topic.
Yes, thank you. Thanks, Martin. Sorry, I needed to leave. Morning, everybody. I'm Sue McLaughlin. I'm one of the clinical directors with the Trust. I'm just going to share my screen. Hopefully you can let me know when you can see everything.
Yeah, that's fine, Sue.
Okay, perfect. Thank you. So I'm just going to very briefly talk you through what we're doing to reduce staff assaults. I'm going to focus on Prospect Park because that's the area that I cover. I'm sure that everybody already knows that, violence towards healthcare workers is a huge problem. You're much more likely to be assaulted if you work in psychiatric settings. We've had decades of research and recommendations that focus on training, post-incident review, but it still remains a problem. And a lot of staff do still see it as part of their job, and that does add to the difficulty. Within the Trust, we have seen some reductions in terms of physical assaults on staff. We do still have pockets of areas where we do want to focus in, where the assaults seem to be higher. We know that there's certain things we've put in place already that have helped, and that's been around having very consistent care planning based on the risk and the needs assessment, paying attention to our seclusion reviews, and we've got a new template that guides staff on what to do after a review. Some daily safety huddles. These are part of our quality improvement programme, and that's where staff come together very quickly every day to focus on changes, things that might increase risk, and then make sure we've got a really good plan for that. We're doing an intervention called Safe Wards, and that consists of 10 modules. We're refreshing 3 of those in particular, and that's about making it very clear about what we expect in terms of respect and what patients can expect. De-escalation, how to recognise incidents really quickly. When we've reviewed our CCTV footage, we can see that incidents were brewing and things weren't always dealt with really quickly. So we're doing some work to address that. And then bad news mitigation. Often staff assaults will occur when a ward round message is being delivered in a very quick way, or where there's going to be a delay in implementing something. So we've done quite a bit of work around that. I guess the biggest area of focus is our zero tolerance policy. And really trying to make sure we're reporting incidents. We've got a letter from Julian if there's persistent abuse to our staff that we can use. Just really giving that message that it's not acceptable to be abusive and aggressive towards our staff. And then making sure that when an incident does happen, we've got police involvement and we follow the necessary route to make sure that things go, proceed to prosecution where that's appropriate. We've got a lot of work to do still around this agenda. We are still gaining an understanding of the data. We're trying to focus on the areas where we can see there's increased prevalence of incidents, but we need to understand that more, because that can be due to other things like a high turnover of patients. Rose Ward, for example, is our particularly high award in terms of physical abuse and aggression to staff. But it's a ward that also has a very quick flow through and more acuity and complexity of patients. So we're trying to unpick that. We're trying to unpick triggers. We know that vaping, medication refusal and leave, as I mentioned, bad news. These are all triggers to staff assaults. So we want to get a better understanding of those through a really robust dashboard. We also want to understand staff factors. We know male staff are more likely to be assaulted than female staff in some areas, but not all areas. Ethnicity and age, we can also see some patterns there, job role and agency versus regular staff. So we're just unpicking all of that at the moment. We want to understand the impact of things like autism and self-harm, because we can see that in the assault data. Flow through the system and bed occupancy, particularly length of stays having an impact. And then perpetrator factors as well, things like age, gender, ethnicity. But we just need to make sure we're looking at the data through a really objective lens, because there's a lot of preconceived ideas around all of this. We're looking at the impact of all our restrictive practices, diagnosis, and also the quality of our risk assessments and care plans, and looking really to see if things could be predicted and therefore prevented. A big piece of work we're doing at the moment is making sure that our zero tolerance policy has some teeth. We're working very closely with the police. We've set up a new panel at Prospect Park Hospital to make sure incidents progress, and hopefully where it's appropriate to prosecution. We're working on our information sharing protocols, because sometimes they can hinder when we're wanting to share information, particularly CCTV information. looking at advanced care planning, making sure our patients are getting the right care and they're not having unnecessary restrictions placed on them, because we know that that can be a big trigger. And then also our staff support is a huge part of this. We've got our nurse consultant network doing a lot of work on restorative supervision, working on the leadership roles on the wards, and reviewing all of our existing processes around how we manage incidents, particularly around reporting, capacity assessments, all the things that we know can get in the way of things not being dealt with in the appropriate way. That's a very, very quick update on what we're doing. I hope it's made sense, and I'm happy to take any questions.
Sue, thank you very much. Very clear presentation. Really important topic, because I mean it's as I know Julian reminds us regularly that it's awful to come to work and expecting to be assaulted. I mean, it's just unacceptable. And I know these are complex issues, and I think you've explained some of those complexities and trying to get beneath the surface. So thank you. But we've got some questions, so if I can just check. John Wellams first, and then Ros.
Thank you. You've described how you're collecting data, how you're having a brief huddle, for want of a better description, in the morning. To what extent can you start to be proactive in anticipating when, particularly if you're seeing a patient for a multiple number of times, that you can actually reduce the risk?
Yeah, I think you know, when we look at our CCTV footage, which we do in a kind of random way to try and learn more about these incidents, we can see that at times we haven't been proactive enough, and sometimes it's the small things. Sometimes they're mental state related. For example, if someone's getting more agitated, pacing, intervening early at that stage without being too restrictive. But sometimes these incidents are not necessarily mental state related. And I think we can get better at predicting from previous incidents in environments and looking at previous history and what's happened beforehand, so that we can do work in a more proactive way, even maybe before people come into hospital, around expectations. Another area is around when we're restricting things. We're not always very good at explaining to people before they come in what they can and can't do and bring into the hospital. And that we've seen in the data, that's a real red flag. It's a real area of frustration that sometimes can lead to staff assault. So I think there's a number of things that we can do in terms of that kind of predictability and preventability in advance. But I think ultimately that really clear message about this is not acceptable, and then following it up, is going to be the thing that has the most power to prevent, to be honest.
Okay, thank you very much. Thank you, John. Ros.
I think you're on mute, Ros.
Sorry. Yeah, it's great to see all the good work that you're doing on this. I just wondered, what's the position with regards to patient assaults by other patients? Because I assume there must be some overlap, and sometimes, unfortunately, it might be another patient that gets assaulted rather than a member of staff. Is there similar work going on with that?
There is, yes. There is some overlaps as well, because sometimes it's during a patient-on-patient assault being prevented that staff can get assaulted, but there is a big work stream going on around that agenda within the wards. And some of the things actually are quite similar around, you know, what's expected, respect, the culture on the ward, that clear leadership and the safety huddles. You know, they're all quite similar things that we're doing on both work streams.
Thanks.
Okay, well, Sue, thanks very much indeed for the presentation and for coming back on your busy day. And can I just, I think, just reflect on how lucky we are to have someone of your commitment to this sort of topic. So thank you very much for all you're doing. Really appreciate it.
Thank you.
Okay, we better move on. Item 10, then committee steering groups. I think we can probably sort of take it as read unless the chairs of these want to raise anything particular. Anyone want to raise anything particular? Graham? Oh,
well, I'm not a chair of either.
No,
groups, but my usual pedantry about layout and punctuation. I do suggest that in the excluded members review process, which is on page 51 of the pack, there's 4 bullets. The 4th one starts draft a report. I would suggest that there should be a comma after trust and another comma after the next trust, because I think it's got to read the excluded member has had with the trust or with third parties about the trust. I don't think it's excluded member has had with the trust about the trust. I think that would be a given. And I think it made the excluded member might have some correspondence with the trust, which might have nothing to do with his exclusion or her exclusion, and therefore shouldn't be part of that. So that's pedantry there. Further pedantry about punctuation there and punctuation indeed and layout in the actual constitution, because I found it's totally inconsistent. What I'll do, if you'll permit me, is do that by email. I won't bore you all with that now.
Yeah, so at the AGM this afternoon, of course, we'll be asking members to support these changes, but I've seen there's nothing of substance there. It's more about presentation. Correct?
Well, in a sense, the substance of my point about comma before and comma after could make a difference to the meaning of that bullet point. And that's why I'm suggesting it is important that we do that. But the other stuff is simply layout and punctuation. It's just to get some consistency.
All right. Thanks for that, Tom.
Thank you. Well, I've just hoped to draw your attention to this fact. We had a presentation, as you know, from Sport in Mind, and the fact that Sport in Mind working with the Trust Research Department. Now, I mean, this is a great charity, started in Reading, worked with the Trust a lot, and it's being spread now, working with lots of other organisations and spreading widely, feeling the heat of funding at the moment. But anyway, it's working with the research department and trying to really assess what these outside organizations working, charities and so on, working in this area, how they affect the trust itself and its workload, the readmission rates and all this sort of thing. So I think that's something that we perhaps could come back to at some point and hear from the research side, whether there is anything that can be done further about this. Because I think that is really important to know, because there's significant money goes into all this sort of thing. And then just to say that at our next meeting, we've got Lorna McCardle of Support You, an LGBT plus charity, and I would rather hope to link up with the LGBT network to invite people to, if they are able during the day, perhaps for 20 minutes or so, or 20 to 30 minutes of the talk, to join us. That would be immensely helpful to see whether this sort of charity in particular, whether they've got something to add about the relationship with the work of the Trust as well. So thank you very much. All governors and board members also welcome.
Thank you very much, Tom. If you're happy and just conscious of time, perhaps we can move on to item 11, the executive reports from the Trust. We've got 2, patient experience Q1 and the performance report. I think we should take them as read, but if we could get any questions for Liz first on patient experience Q1. Tom, is your hand up again, or is that left up?
Yeah, it is. Well, it is up again, and it is up again.
Okay, all right then.
Right, it is up again. And the thing that I think is that this report, I do believe it could be much better presented. For example, I mean, just as a simple thing, the divisional headings are not distinguished. You can't make out where you are in the report. And about 5 years ago or so, the quality accounts were really radically improved in presentation, and Jason Hibbett and Amanda thing where really had a go at them, and they're much better and clearer. And that's a matter of efficiency and getting information across. So I really think it could be improved, and perhaps whoever puts this together could actually get together with Jason Hibbett if he's still doing quality accounts, and they could put their heads together. But I just think it would help the board. I know it's the board's report, it's up to the board, but I think it would help everybody to just revise the presentation and just clarify it, get some standard sections into the text, break it into standard sections, and then it would really be a lot easier. And there is something, there's a point at which there's a heading that seems to have got stranded as text in the middle. I don't know if anybody reads this stuff through, but it's obviously wrong, but you know.
Tom, thank you.
Thank you.
Okay, I think the board will take note, put it that way. Graham.
Yeah, comment on the way in which some of the text around some of the numbers, I just question it. In I think the overview on page 59, there's a table, what are the implications of the EDI and the environment, with ethnicity, complaints, patient survey, breakdown of tendencies. Now that table is then replicated in the main report on page 73. And the reason I raise it is in that text, it says, we have a higher number of complaints received compared to attendance percentage from those with Black British heritage. And there is still more feedback being received from White British as a percentage of contacts than from others. Now, if you look at the comparison between the percentages of attendances and complaints received for Black British, attendance is 2.67%, complaints received is 2.94%. So yes, I agree, marginal, but there is an increase in complaints received. However, for White, the same numbers are 66.66% attendances, 83.82% complaints received. So I don't think it's true to say that it's simply feedback received from White residents. It's complaints received. So we pick out complaints received from black identifying as Black, but we don't pick out complaints received identifying as White. And I do think we need to just be careful about the language we're using here.
I'm afraid the details I find difficult to follow online in the meeting, but Graham, perhaps Liz has got some of that, and she'll think about that and come back if that's all right. Thank you, Guy.
Yeah, thank you. I've got a compliment on the performance report. The metrics, the numbers showing month by month. I found it really interesting and helpful. So thank you for that change.
Thanks for that, Guy. It's a performance report in the form the board gets it as well. So it's Tom, is yours a new hand?
Yes, it's a minor it's a technical point, but I think when you look at page 70, this is page 73, ethnicity, we note that the patient survey responses show other ethnic group as 7.21%. So I think what this is showing is actually that the feedback somehow is not capturing the same categories as we use elsewhere. And I get a bit of an impression, and I might be wrong about this, that I Want Great Care are not terribly flexible about what the trust really needs. But anyway, maybe this is something that shows the categories aren't quite right. Thank you.
Okay, Tom. Again, I personally didn't quite. Liz, did you understand that? I didn't understand it.
Yes, I did. Thank you, everyone, for your feedback, and I'll take that on board. You're right, Tom. It's because they don't exactly marry up. So you're absolutely right.
Okay. Well, thanks for that, Tom. Thanks, Liz. Okay. If we may, we'll. If there's no other questions on those two reports, can we move on to appointment of lead and deputy lead governors? It's time for us to agree, or you to agree, to approve the reappointment of Brian Wilson as lead governor and John Wellham as deputy lead governor for another year. I think there are no other contenders, so are we content?
Very much so.
Thank you. In which case, Brian and John, thank you very much. Congratulations. Item 13, governor feedback session. Any particular things people want to raise of a general nature you've interacted with? We've had sport in mind raised, but okay. Any other business of any sort? Graham.
Sorry, I thought Brian might raise this. I will. My question is why we have decided to have the AGM as a virtual meeting rather than as a hybrid. You know, I think it sends a message, perhaps sends a message to our members. Also, there's a question about how that decision was arrived at, because the point was made in our pre-meet that this is a, it is the members and therefore, to that extent, the governors who have a role within the AGM process and outside the formal agenda. So it's a little concerning because I think we're all used to getting back to physical meetings, seeing the whites of people's eyes, having an interaction that is not the easiest online. So the question as to why we've gone down this road.
I think the answer to that is that we felt it was gave access to a wider range of people. Hybrid meetings, particularly if they're large ones, are difficult to manage in terms of the interactions. And indeed, it's interesting that the Bob ICP is now moving to entirely online meetings. So I think the idea of going back to face-to-face for normal business is not quite as popular as you might indicate, Graham. So I think that's the reason. It's because everyone can get onto it. We know who they are. You can see who the people are when they're speaking. It's a much easier process. I don't know about the formality of it, Julie. I think it was me that decided, but
well, can I just comment on that? I mean, I've been involved in a lot of hybrid meetings, many, and to my mind, they work very well. They allow those who can't physically attend to interact. There's generally no difficulty in taking questions from the ether and answering those questions. I just do think that the dynamics of a physical meeting are very different to the dynamics of a virtual meeting. Personal view, but there you are.
We had it, of course, we had it face to face last year, and not many people from the public turned up.
Yeah, which is why I applaud
staff or governors.
Which is why I applaud hybrid.
Yeah. Okay. Well, we can perhaps it's a bit late now. We've got the meeting this afternoon, but we can talk about it with governors for next year. Tom.
Yeah, one thing I want, there's a question from Sarah Croxford in the chat, by the way, who can't raise her hand.
Oh, sorry.
Yeah. So, but I just wanted to say, looking at the board's the many indicators that the board looks at, I saw that a lot of the ones that a trust is doing well on are gradually drifting downwards, and there's sort of an indication of wide general stress. It might not be a surprise that the atmosphere, the environment is very stressful at the moment, but it would be just say it's important perhaps to just, if that's the case, to be aware of that, because if they all turned red in a short period, it would be grim. And they are drifting downwards. It's just that there's a sort of, I looked at it as demonstrating a systemic stress throughout the organization, and just to point that out, that's what the message was to me.
Okay. Thank you for that.
Thank you.
We got a question, as you said, from Sarah. So Sarah, do you want to speak to your question?
Yeah, that's okay. Apologies. I probably need to run a Teams update, which I think is probably causing me a challenge. Yeah, the question is actually relating to partly to the patient experience piece. And there was a recent communication from Amanda Pritchard that I saw around the Oliver McGowan Autism and Learning Disability Training for all staff. And I'd just be very grateful if we could get an update in terms of where we are with all of that against level 1 and level 2 training, to understand whether all of staff have now completed the mandatory training, and whether that's been helpful as an effect for patient experience as well. Thank you.
Yeah, I can answer that. So we've got level 1 as mandatory. People got to do it during the course of this sort of financial year. There's been mixed feedback actually on the quality of the training that's been rolled out. Not the reason why. Some have found it very long. In terms of its engagement, because it's online training, mixed picture really. So the people who've done it have definitely benefited from it, but the quality of the training has not. People have found it a bit turgid, actually. The length of time it's taken and some of the key messages are somewhat obscured as a result of it. But in the absence of anything else, we will continue to do it, but it's certainly our experience. And say, for example, when we put a bespoke package together about online training about information governance, for example, it'll be short, it'll be sweet, and it'll hit you between the eyes about the things that kind of people are likely to be confronted with in their day-to-day work. And it probably doesn't hit that mark at the moment. So I think there's probably some refinement to the national training. My understanding is that the level 2 is yet to be finalised for NHS.
Yeah, I was under the impression that had been released now, but I think it is more a case of understanding, if the training has been useful, what's the net effect, I think, for staff and for patients, appreciating obviously the training complexities around the length of it. It is very long, having reviewed it. But I think any form of training that helps support both that experience from both sides is hugely beneficial.
I agree, but what we might do is get hold of it and make it impactful.
Yeah.
Longer is not better, particularly online training. So I think people have found it very helpful. We've had some really good conversations, and it's part of our sort of the wider piece of work around our autism strategy, which Mary Evans has led. So placing it in that sort of context around certainly the increasing awareness, understanding, confidence, and increasingly we're starting to see it in other pieces of work. So, for example, Sue McLaughlin, when she talked about violence and aggression, really understanding. So every piece of work we're doing now, we're certainly seeing a greater focus, understanding, curiosity around it, which is helping. It's difficult whether we could attribute that to the training in itself, isn't it? The kind of causal factors, but it's got to play a part, I would have thought.
Yeah,
Thank you.
So I've done the training level 1 as well, and I agree with you. I have to say I think it's a dreadful training package, and it gets in the way of a really important topic. So I think if we can shorten it and get it clearer, I think it'll have more impact. At the moment, the style gets in the way of the message, which is a pity, but hopefully that can get improved. Anne, over to you, Anne Jumba.
Thank you. I was just going to add on to what Gillian has said. As a member of our staff who has done the training, it's lengthy and it's also useful. From my team, speaking from our team side, working as a community matron, because we are more ranged with working with the different people, we find that the learning disability people will lead on more on the patients with the difficulties, and we are not so muchly involved in it. However, doing the training enabled us as staff to have the knowledge and understanding when you are visiting families who have difficulties, you are able to support them in a good way. But the training itself was lengthy. People struggled to complete it. But overall, it's worthwhile knowing and having that knowledge of understanding and how to support families and those who are struggling. Thank you.
Thank you for that from the front line. Very helpful. John Wellham.
Yeah, very quickly. I unfortunately had to be tutor on these online packages, and what I found worked with my groups was I gave an overview before they sat down for 1.5 days and worked through it, and then was able to say any questions at the end of it. So that might be an approach which could be available.
Okay, John, thanks for that. All right, I think we're coming to the end. The date of the next meeting is 1st of November, Joint Trust Board and Council of Governors, and the 7th of December for the formal governors. And we've got the AGM this afternoon. Mark, you had your hand up.
Yeah, Martin, just point of clarification. In my diary, I've got the December meeting as Wednesday the 6th, not Thursday the 7th. Is that correct, or has it moved?
I wouldn't know, Mark, but I'm sure Julie knows.